Good afternoon. This is UMAC TV, United Medical ACO. Today is June 3rd, 2022, Friday. As always, we are here to give you our routine updates, weekly routine updates, as well as some new topics. And we do have a clinical presentation today. Our guest is going to join us soon. Sean is here as usual. Sean, how are you doing?
I'm doing well. Thank you for asking. How are you?
Good. So we have our regular COVID updates. Monkeypox. I was going to say something else, but monkeypox updates, and then we'll go into our clinical presentation. And right after that, we have our other updates. As much as we have the hoping that we would have enough time.
Yeah, depending on the time, we have a few items lined up.
Yeah. So let's start with our okay, here is our COVID.
So just as another announcement too, before we dive into the COVID updates, we are in June now. So this is a few months to take note of. It is Alzheimer's Awareness Month, it is Pride Month, and it is also Men's Health Awareness Month.
So I may have the wrong video, and then this time I did go through everything properly.
There may be a more recent one that was
let
sent.
me check.
The COVID updates would be the same though, so I can talk about those in the meantime.
Hold on, this is June 3rd. So I did open it, but because we have our same files. Okay, go ahead.
Okay, so good. Perfect. Yeah, so again, it is Alzheimer's Awareness Month, Pride Month, and then Men's Health Awareness Month as we go into June here, which seems like time is flying by. That's already almost the summer. But as we know, that is an impact the weather on COVID, at least in the recent variants that we saw, that the summer months tend to have lower cases and lower severity, which does seem to be the case here as we have the numbers slightly dropping off now. We did see that small increase.
There was a 250,000 case.
There is. Yeah. The cases were up, but now the graph actually is slightly plateauing, kind of decreased a little bit, but nothing compared to the Omicron in the winter. Again, we always reference that. Mm-hmm. But just to remind everyone that the cases, even though they are increasing a little bit, the severity and symptoms and overall the death rate is not as severe as what we have seen with previous variants. So it is optimistic in that sense. And then just from a numbers stance, the US on the recent week daily average was still over 100,000 cases. As you mentioned, there was one day where it was over 200,000, 250,000 in a single day. So we did have the Memorial Day weekend, which may have been people getting together, extended weekends that also may have skewed.
I know several people who don't have COVID, but they have different, some viral infection.
Yeah, so upper respiratory of some sort.
Yeah.
A lot of people are coughing, yeah. Could be another strand or variant developing or just another unrelated, but there are other illnesses out there too that people should be aware of. And then just number-wise with the vaccination updates, as a nation, we were at 221.5 million people fully vaccinated. And with the booster, over 103 million have received one, with about 14.7 million having received a second booster. And then we always do compare the state of Delaware in the right-hand column. And actually, it only increased in two of the categories. I believe it was above the ages of 5 and then the above 65 years old, each increased by 0.1%. The other three did remain the same. So we are seeing a plateau there in vaccination numbers in the state of Delaware.
All right. So we'll go into our clinical discussion from here. Dr. Hosmane is waiting. I don't see Donna.
Can send her a message that we are
or maybe
good.
She's just waiting for me.
Yeah,
to say,
she's just waiting for
Donna.
Yeah, okay. So if she's hearing us, you're good to join, Donna.
Yeah. So let's see. She's there. So in the meantime, I'll bring the. What happened? I just realized now. So while we're waiting, is Donna,
I sent her a message, so she should be.
the videos that I actually uploaded, I was on a different session. It didn't save it. So that's why
For your background.
all that prep work that I did is,
Try to get ahead.
that's fine. Although we have everything else here.
Yeah, we did have a few videos. So we had a little bit extra material than we're used to, but
Well, it's like a TV channel now, so we have so many videos.
So much to manage, yeah.
So now I'm going to let Dr. Hosmane in. Oh, there's Donna. Dr. Hosmane, how are you doing?
How you doing, Kemal? Good afternoon.
Good afternoon. Donna is also with us.
I'm here.
Hi, Donna. How you doing?
I just want to make sure. Can you hear me, Kemal?
Yes.
Okay.
Can you hear us?
Because every once in a while it doesn't work.
Dr. Hosmane was asking how you are doing.
Oh, I'm doing good.
Great. Good to see you.
Yeah, it's good to see you.
Dr. Hosmane, thank you for joining us. So I believe this is your second time with us in this show. So we have done, we are working on our format. From the primary care point, we did actually present, I believe, 7 different topics. And then we are going with the same topics, but this time we have the specialists who are whose specialties in those topics. And today is the hypertension and congestive heart failure is our topic. So the format is a little bit different than what you used to. The video is running in one of the windows, and then you are actually, if you can please introduce yourself briefly, and then we'll just start, and we may have some questions for you.
Sure. I'm Dr. Vinay Hosmane. I'm a non-invasive cardiologist here in Wilmington, Delaware, which means that I take care of people's hearts in a non-invasive way. I don't do any surgeries or heart catheterizations, but we do a lot of cardiovascular prevention, examining heart valves, examining heart muscle, treating blood pressure and high cholesterol, taking care of things such as shortness of breath and dizziness and people who pass out and abnormal heart rhythms. And I'm also a part of the United Medical ACO as well. Thanks for having me.
All right. So now we wanted to talk about the the hypertension and the congestive heart failure. So Donna, did we have any specific questions in the beginning, or do you want Dr. Hosmane to just talk about it?
Yeah, I was going to let Dr. Hosmane, he had sent some information on a couple of PowerPoints, and so Sean was able to get them in the slides for us. So they'll be running through the loop, and Dr. Hosmane has some notes. So I thought we would let him go first and then ask any follow-up questions.
Sure.
So I think to begin with, congestive heart failure, we teach our medical students is actually a symptom. We actually use that as a catch-all term. So technically, heart failure is a symptom of either a weakened heart or a stiffened heart. And we usually break down, congestive heart failure into a weakened heart, which means you have a problem with your heart pumping. So you don't have good forward flow, or people can have a heart that's stiffened where the heart doesn't fill with blood. And the end result of congestive heart failure is people will end up having shortness of breath, they'll have fatigue, they'll have lightheadedness, dizziness, they can get swelling in the legs. And our goal is try to educate on congestive heart failure. We don't want you to have a congestive heart failure, and that's part of what the ACO is also trying to do, is try to prevent congestive heart failure before it happens. And 6 million Americans actually have congestive heart failure, and that's actually the leading cause of hospitalization in patients over 65. It's a tremendous cost to the healthcare system. and it really burdens patients and families and caregivers. And as our population ages, of course, we're going to have more and more cases of congestive heart failure. And congestive heart failure is diagnosed clinically at the bedside or with a stethoscope, in the exam room, and it's also diagnosed with with an echocardiogram, which is an ultrasound of the heart. And when we talk about heart failure, we don't want to end up in heart failure, so we start looking at how can we prevent it before you get heart failure. And we also want to, if you do present with heart failure, unfortunately, we want to also figure out what caused it. So basically heart blockages or heart attacks, diabetes, high blood pressure, abnormal heart rhythms, bad heart valves, obesity, sleep apnea, inflammation of the heart, such as viral illnesses. We've certainly seen a lot of heart weakening and stiffening and congestive heart failure with COVID, unfortunately. Autoimmune disorders can cause congestive heart failure, as well as cancer drugs. Congenital heart disease, if somebody has, say, a hole in their heart or a bad pipe or a bad valve in the heart, they can end up with congestive heart failure. And, one thing we always talk about is people get worried about swelling. And sometimes swelling, it gets you an immediate visit to the cardiologist, but all swelling is not congestive heart failure. A lot of us do have swelling in the legs chronically from bad veins, those of us who stand on our feet all day. But definitely, if you do have swelling in the legs, we do think it definitely should, warrant a trip at least to your primary care doctor. If you have swelling in the abdomen, the swelling going from the feet up to the legs, that's a warning symptom. If you have trouble laying flat at night, that could mean that you have congestive heart failure. If you have shortness of breath, walking a certain distance that you could walk before, those are warning signs. And just to kind of wrap up a little bit and let these guys ask some questions, we'll kind of give you guys some food for thought to ask some questions. What are the treatments for congestive heart failure? Well, the first thing we like to do is make you feel better, get rid of your shortness of breath, get rid of your swelling. So we have a lot of good medications for that. We have diuretic medications. Those are medications that pull out fluid. As I mentioned before, congestive heart failure is a problem with the heart pumping blood or the heart accommodating blood. And as an end result, you get a backup of fluid in the body. So that's the main issue with swelling and backup of fluid. So we start using diuretics to get rid of fluid. We start using different blood pressure medicines to regulate how the heart functions. We also advocate weight loss and a low sodium diet, because sodium helps you retain fluid. And in congestive heart failure, we're retaining fluid, so that it compounds the problem. And we also advocate cardiac rehabilitation as well. And ultimately, we also want to start looking at the root cause. What was the root cause to get you here in the first place? Did you have a heart blockage? Did you have a viral illness? Do you have a bad diet where you're retaining salt? Is your blood pressure not controlled? Do you have a autoimmune disorder? Do you have sleep apnea? And if that's the case, then we actually want to get to the root cause and treat those to get you out of congestive heart failure. So I try to run through some real quick. I know I gave you a lot of little tidbits there, Kemal and Donna.
You mentioned the sleep apnea, and the treatment for sleep apnea is, if it's coming from, let's say, if it's morbid obesity, they have to lose weight. If they are smokers, they have to stop smoking. But if they don't do one of those, or if they don't have those problems and they still have sleep apnea, then they need to be on a CPAP, right?
That's correct.
So, not using a CPAP would actually trigger this issue. Is that
correct? You're correct, because sleep apnea causes a drop in oxygen at night, and as a compensatory mechanism, you get the pipes in your lungs vasoconstrict or clamp down, and that and some other mechanisms occur, and that as an end result results in high blood pressure at night, and that high blood pressure or hypertension at night, despite being on good medicines during the day, the blood pressure at night gets very high, and that can actually cause a load on the heart and weaken the heart. So yes, untreated or inadequately treated sleep apnea or non-compliance with CPAP can lead to congestive heart failure.
So the reason I'm actually, because as you know, we do have our daily case conferences. Donna and I now, we are actually running one. Each of us have our own groups. Sleep apnea comes with morbid obesity a lot, but then in some cases, if if someone doesn't have morbid obesity, but they do have sleep apnea, if it's not treated, if it's not going to have any harm, like long-term, other than just the sleep itself. But what I'm hearing, and that's why I'm kind of trying to highlight that is, which we can actually, when we talk to our nurses and our care managers, when we have our discussions with the patients, untreated sleep apnea can be connected to the congestive heart failure, because these things are not happening overnight. So as it's not being treated in a timely manner, if the prevention is not there, of course, that's going to be the main problem, which that's what we see every day. Patient has been with us for so long, they didn't do their blood work, and then when we follow up, we find out their A1C is like 11. Their blood pressure is high, and they're not taking medications, and patients do have a lot to do with it, so they are not following our doctor's orders. Now, if we can actually maybe talk about the compliance from the patient. Now, let's say if I see my primary care, and then my primary care did maybe give me medication, and then maybe I didn't follow through as a patient. Now, if my primary care referring me to you for the hypertension or for the congestive heart failure, does it have a big impact? I'm not asking from the clinical side, but from the psychological standpoint of the patient. When they are referred to a cardiologist, now they understand that this is more serious problem, so they have to really actually stay compliant with their medications and then diet and other orders that you are given.
I definitely do think it's a light bulb moment. Some people get very irritated when they get sent to the cardiologist. I don't know why I'm here, but in the background with United Medical and our EMR system, you guys flag a lot of people who are at risk, and it is definitely a scary moment to be sent to a cardiologist. And I do hope that wakes people up, because it's just a shame, because with the modern medicines we have, the generic medicines we have, the availability of blood pressure cuffs, the primary care doctors and who are screening patients for these things, the early detection is there. We have the ability in this country to do early detection. And it's a shame, because sometimes when people come to the cardiologist, Kemal, as you're alluding to, it's often too late. The hypertension is very easily treated by the primary care doctor or nurse practitioners or physician assistants or nurses or case managers. But the problem is when people are not compliant, as you're alluding to, they get end organ damage, they get ocular damage, they get kidney disease, they have heart disease. So they go into congestive heart failure, they have heart blockages and heart attacks, they end up on dialysis. So it's not just the cardiologist that becomes a lightning bulb moment, it's the other specialists. You don't want to get sent to a cardiologist when you have hypertension. You don't want to end up in the nephrologist's office, because that often means that you have some end organ damage. So you are right that heart failure is preventable, very preventable by attacking your hypertension, your diabetes, your sleep apnea, your weight. And I'm glad you touched upon sleep apnea, because that's kind of the stepchild of pulmonary and cardiovascular medicine. A lot of people don't know they have sleep apnea, and you kind of alluded to the fact, well, what's the harm of not wearing CPAP? It's just affecting my sleep. It's not just affecting your sleep. And if you tell a medical student or a nursing student to Google the side effects of untreated sleep apnea, they almost don't believe it. The list is like 20 long. It can cause you to be fatigued. It gives you high blood pressure, promote diabetes. It can promote high cholesterol, promote erectile dysfunction. People die in their sleep from bad heart rhythms, and not to mention congestive heart failure. And I think the other point that you were trying to get to is that in the bariatric program, you guys screen everybody who's obese for sleep apnea, but you were making the point that it's not just obese people that have sleep apnea. Even thin people could have sleep apnea. And that's one thing that people don't realize. When I was in medical school, we all focused on people who were overweight or obese, and it was only the 300 pound or 400 pound person that was unfortunate to have sleep apnea. But we have people that are thinner than every one of us on this call that have sleep apnea, and they're like, oh, they're skinny, they're healthy, but we should even screen people who are thin and normal body weight for sleep apnea.
So Dr. Hosmane, one of the things I wanted to bring up, and I think it goes along with the compliance, but as you know, when the doctors put in the orders to see a cardiologist, usually it's our care coordinators who outreach to the patient. And, sometimes what we hear is, oh, but I feel fine. I don't have any symptoms. I don't think I need to see the cardiologist. So if I hear you correctly, that's part of the problem, right? They may feel fine because they may have gotten used to having a blood pressure high. And
Correct.
so their body kind of gets used to that and they can function, but it's when they really do start feeling bad that they've kind of surpassed that. So I guess one of the things we just wanted to make sure we emphasize is getting to the cardiologist early, because it's better to get there early and maybe only be seen once a year so that you can track if anything starts to happen or worsen, and then you're better able to proactively treat that.
Definitely. I mean, I think number one, even before that, it's very important to see your primary care doctor, not just have a primary care doctor in name only. You need to show up for your yearly visit. You need to show up for your Medicare annual wellness visit. You need to have a primary care doctor because that's your gateway to get your blood pressure screened. So I think that's number one, is you have to see your primary care doctor or your nurse practitioner, your physician assistant yearly. And when you are asked to go to the cardiologist, as you correctly pointed out, you want to see the cardiologist. Sometimes the primary care doctors will send patients over to us, even though they feel fine, because they've seen something subtle. They've seen something on the EKG, a minor abnormality on the EKG. They've heard something on the heart exam. They've seen the blood pressure start to creep up. They wonder if there's sleep apnea. A patient's exercise tolerance may not be what it is. A doctor may notice you being a little short of breath rushing into the office. So there's a lot of different clues. Even though you feel fine, the primary care doctor may have some clues, and a lot of times sending somebody prophylactically to get a proper EKG, to get a proper ultrasound, because that also helps the primary care doctor decide, have I treated the blood pressure adequately? Because a lot of times what happens is you get one snapshot blood pressure in the doctor's office. It might be 120 and it might be good, but you don't know whether you're hitting 140s, 150s, which is considered uncontrolled high blood pressure in the outpatient setting. So oftentimes patients come to the cardiologist for a second set of eyes and to make sure you don't have any end organ damage in the cardiovascular system.
So, Dr. Hosmane, the physical activity as one of the preventions, and I guess it's part of maybe the treatment as well. So as we see this issue maybe more with after a certain age, I'm not going to say elderlies, but as we are getting older, what type of physical activity are we actually talking about here? Like, is someone, are we saying that someone has to do like a 1 hour cardio every day? Or if it's okay for them to just do 30-minute walk, or do they have to play tennis? Are you still playing, by the way?
I'm still playing every Thursday.
I just played last Wednesday night.
Good.
So twice a week. So that's our stress test, right? So I don't.
Yes, exactly. Or we always, a good equivalent is being able to walk up a flight of steps without having any chest pain or shortness of breath or fatigue. That's also a good measure of cardiovascular health. And I think they've also had how many push-ups you can do. If you can do 20 push-ups, you're good cardiovascular health as well. But the exercise is a moving target. And as you guys have both know, that the exercise recommendation has constantly changed, right? It's, I think the American Heart Association will say 150 minutes of moderate exercise or vigorous activity a week. So at least a fast walk or a brisk walk should be done at the very minimum. And also I think the other comment is at the very least move more. And so there's a lot of us who can't go out for a 30-minute walk, a couple times a week or 5 times a week. It just can't do it physically. Some people have bad knees. There's different physical injuries you get when you're on the wrong side of 40. So I think the biggest thing is also increasing your steps and moving more. Before COVID, we would tell our patients when they go to the grocery store, make sure you hit every aisle. When you go to Walmart or Target, even though you're picking up one thing, it's air conditioned and heated, walk up and down every mile. Try to park further when you go to the mall or the grocery store. I do think that trying to do something every day would be the optimal setting, 30 minutes of at least a walk 5 days a week. If you can play tennis, or you can jog, or you can use a row machine or a stepper and get a little bit more vigorous than a brisk walk, we do feel that that's helpful. There is actually a J curve with exercise. So, your mortality and morbidity comes down with exercise. And when you start getting into marathon running and these ultra marathons, the actual risk to your health actually goes up. But for most of us on the wrong side of 40, that's usually not a problem. But playing tennis twice a week, walking on the days that you don't play tennis, trying to increase the number of steps, trying not to sit. As we all know, sitting can actually injure your health and hurt your metabolics, give you diabetes, make you more prone to hypertension, high cholesterol if you sit. So trying to use standing desks, trying to get up every hour and take a walk and walk around. A lot of people are working from home. So you really need to move more. And
I think that's the key too, is sometimes when we are talking to patients, they're like, well, I can't do 30 minutes, and having them understand you can build up to it. Even if you start with 5 minutes and the next week it's 10 minutes and the week after it's 15, you have to start somewhere, and them understanding it's building the endurance. It's not going to happen overnight. And it doesn't mean if you can't do 30, then you shouldn't do any.
Correct.
So I think that's just another point for everyone to understand you can build up.
Right. And some people may not be able to walk 30 minutes. They may be better off on a recumbent bike or an exercise bike or a row machine. Or if you can only do 15 because you're severely limited by bad arthritis, at least do the 15. Right. You can also do some stationary things. That we also know now that high intensity training and weight training and resistance bands are also helpful, because that can actually increase your heart rate. There's something called the Johnson & Johnson 7-minute workout, and there's a free app from Johnson & Johnson, and that's a phenomenal app. I have some of my patients, 50s, 60s, 70s, 80s, that are actually doing that, and it's basically 7 to 8 minutes of exercise that you can do in a very small area. And you can improvise some of the exercises. Some of the things are sitting up against the wall for 50 seconds, resting for 10 seconds, doing jumping jacks for 50 seconds, resting for 10 seconds, holding yourself up in a push-up position. If you can't do that, you can put your knees on the ground and at least lean over with your hands. So there's nothing that says that you can't pick and choose which one of the exercises work for you in the comfort of your own home. Nobody's watching you. And also when it comes to walking, when we say, people ask, how fast should we walk? You should walk at a pace that you could still walk and talk to somebody. So we tell people to go ahead and walk, talk on your cell phone or talk to your friend. And if you start getting a little short of breath when you're talking, peel it back. So it doesn't have to be a very fast walk.
No, those are all important. I think one important thing that I heard from you, like other than other important stuff that you have, I'm just thinking about our parents. So you and I, we're about the same age, and our parents are about the same. So, and I talk to my mom every day. So one of the things is that sometimes she doesn't really go out enough. But I think going out to a store and then just hitting every aisle is ideal, because they don't have to be out. They don't have to worry about if something happens to them while they're walking, there's always someone who can actually help. So, we can tell our patients that go to ShopRite, Acme, or Jansen's and just walk around, and then you don't have to buy anything. Don't buy anything unhealthy. But I think that would be a good way to, or just go to the mall and then just walk. But you don't want to, stuck in the hospital for something that is preventable. And that's kind of like our main focus. I know we do work on a daily basis with your office when we have our patients. Sometimes from the care coordination team, we are supporting the primary care setting in a way that if we feel like patients are like they're on certain medication and their blood pressure is still not under control, same thing with the other values, like the A1C is not controlled. We do engage our specialists as part of our clinical integration. And so far it works for us, and I know it works for our practices. Anything you would like to add
Yeah, I think one thing I want to add, and I think from the education standpoint, as you guys know, what is hypertension, what is high, what constitutes high blood pressure has actually changed over the years, right? A systolic blood pressure, or the blood pressure top number 120 or less is considered normal. 120 to 129 is pre-hypertension. 130 and above is stage 1 hypertension. And I know the care coordination team sends people over with people they're on multiple blood pressure medicines and their blood pressures are still running 140. And they want to know, why are they here? My doctor sent me here. Well, I don't really need to be here. That's not hypertension. Unfortunately, it is considered hypertension. So the numbers have dropped. And I think a lot of our clients and a lot of our patients are not educated on that until care coordination or somebody in their doctor's office tells them, you need to go to see the cardiologist, you need to see the nephrologist, or you need to come back to the primary care doctor a couple more times. And suddenly they switch primary care doctors and they come into the United Medical ACO and a new doctor sees them or a nurse practitioner sees them and they say, well, we need to add another blood pressure medicine. And they're like, what do you mean? My blood pressure is good. What do you mean? It's 140s at home. Well, 140 is not good. And so people get very skeptical when a new provider sees them and all of a sudden they've been seeing another provider out of state or a provider who's retired and they've been controlling the blood pressures at 140s. Well, 140 is not controlled. It's definitely not controlled if you're on medicine. There are a select few patients that are elderly that may have some blockages in their neck or their blood pressure drops when they stand that we do have to run at 140 or 130, but those are the exception. So I think we definitely need to get the message out that 130 and 140 is not a good blood pressure. And now certainly you could have a blood pressure. The last time I checked a couple of weeks ago, my blood pressure was 117. I'm sure if you checked my blood pressure right before I got on with you guys, it might have been 130. When Kemal's playing tennis, I would hope his blood pressure gets to 140 or 150. So blood pressure that's higher than 120 with exercise is okay because the body can accommodate that. You need higher pressure with more activity, but you certainly don't need high blood pressure when you're at rest. And that's when we tend to check blood pressures, right? We tend to check blood pressures, somebody sitting in a chair after sitting for a couple of minutes. And the other thing that people get angry about is when they come to the cardiologist, well, my blood pressure runs 120 at home, and I went to the OBGYN and the blood pressure was 150, and they told my primary care doctor that I'm repeatedly hypertensive, and they get sent to the cardiologist or they get sent back to the primary care doctor for more medicine. So, one blood pressure that's high in a doctor's office does not constitute hypertension. And that's why we're a big proponents of outpatient blood pressure checks, going to the grocery store or the pharmacy and checking your blood pressure after sitting for a couple of minutes, having your own blood pressure cuff if you have high blood pressure, or borrowing a blood pressure cuff from somebody is very helpful. So I think those points need to be made and reiterated.
Well, actually, I was going to ask you the question and I changed my mind, but because now you just made this comment, so I'm going to go ahead and ask you the question. Like, there should be some home devices for our patients, right? So especially now with the telemedicine, it's more important. But each patient should have, like, these are like inexpensive devices, and like there's the white coat
syndrome, the white coat syndrome, yeah, where they're
so but then just do it at home and then let's see, like, and then do it multiple times, and then we can compare. We understand when you are in the office, there may be some anxiety, but when you're at home, then if you can give us the log from home and then say, here's my log, then I have it 5 different times and it is, controlled versus when I'm here, I'm nervous. That can help those patients. Having a scale would help because we need to know how their weight is changing. What other devices that you would think that they should have?
So I think that's a great point, Kemal. And, I wouldn't check your blood pressure 5 times in a day because that starts giving you anxiety. But sometimes when we're trying to figure out, is somebody have hypertension and they're repeatedly high in the doctor's office, or if we're trying to find out if their blood pressure is well controlled when they're on medications, we usually advocate checking the blood pressure once a day, maybe once in the morning, once in the evening. Try to check it around the same time every day. Sit for 3 or 4 minutes before you check your blood pressure. And you're correct. A lot of the blood pressure cuffs are accurate. I get into an argument a lot of time with patients because in our office, we advocate the Omron wrist blood pressure cuff. A lot of people have been told that wrist blood pressure cuffs are inaccurate, but we found that the Omron wrist cuff is accurate, more accurate than some of the other ones. Some people don't like getting their blood pressure on the upper arm when the blood pressure cuff starts squeezing. It's tight, it hurts. So in those clients, we often advocate the wrist cuff. And I will say that a lot of these outpatient blood pressure cuffs that are not manual, they're electronic devices. They tend to go bad much quicker than the manual blood pressure cuffs we have. So usually during someone's annual wellness visit, we'll have them bring their blood pressure cuff in for correlation. So, sometimes you do have blood pressure cuffs that are gone bad and they show a blood pressure of 120 at home and 140 in the doctor's office with our manual cuff. And that patient may not have white coat hypertension and they may really be truly running in the 140s. And I do think that having a blood pressure cuff is similar to having a thermometer at home, right? I mean, you have a thermometer just in case you have a fever, you need to know if you need to take something. And having that in your armamentarium is huge because we also, when we give blood pressure medicines, I mean, it's the art of medicine. So sometimes what blood pressure medicine may work for Kemal may not work for me. Maybe a half dose works for Donna. So sometimes you want to give someone a blood pressure medicine. Sometimes you can overshoot because one blood pressure medicine may be more powerful for one person. So I say have a blood pressure cuff so you can protect yourself from me. You can protect yourself from me over medicating you. You can protect yourself from me under medicating you. And so I think it's definitely very helpful to have that. Having a scale is good, especially for patients with congestive heart failure, to make sure that their weight is stable. If you're gaining weight, it may mean that your heart's backing up fluid. Some people may be better off without a scale. Some people don't get depressed when they weigh themselves. Some people would rather check their belt notch or see how their dress or their suit fits. That's why I'm wearing the jacket today, to make sure it fits and my weight's in check. There are other more sophisticated devices such as heart rhythm devices. We have Apple watches that track heart rhythms. We do advocate those for certain patients. If somebody has hypertension, we don't necessarily advocate they go out and buy an Apple Watch or a heart rhythm watch. But if somebody has a heart rhythm disturbance, we do advocate that. So those are some of the things. There are also some other things that check wearables that I'm sure, Kemal, you'll get into at some point, or maybe already have looked into wearable devices to track patients in terms of how much movement they have, how many steps they have. There are other trackable devices that you can put on different joints to make sure that people are exercising or rehabilitating their joint properly. But from the cardiology side, we don't really get much into that. But I'm sure from the ACO side, I'm sure there'll be a session at one point regarding wearables.
Yeah, I think we are going to. We haven't done one, right, Donna?
I don't think so, no. Mm-mm.
But this is very helpful. I know you are seeing patients. You take time from your office hours to join us. We appreciate that. Well, thank you for being with us.
Yep, my pleasure. Thanks for getting the word out, and thanks for all the support and all you guys do for our staff and our patients.
Thank you.
Thank you.
Take care. See you soon.
All right. Thank you. And I am going to go back to my other job to see if I can pull the right stuff. So we'll do our so let's see.
Maybe we have a few videos there.
All right, so this is the first one.
Yes. So I'll make sure it's the right. Okay, yep. So yeah, the first one, we do have our eye on the monkeypox virus. We know it was spreading. If you see on the first slide, it is up to over 550 cases globally. And then on the second slide, you'll see it's actually been detected in over 30 countries now as of June 1st. So that number actually may have
So
increased.
last week, this number was less than 100.
Yeah. And
So-
we were seeing a few cases in the US. I think it was less
And
than
then when
10
we
still.
reached out to the state of Delaware, the answer was whatever we have from the Health Alert Network,
Correct.
right?
Yeah.
So
HIN.
is what they have.
Yeah, and that
Yeah.
was based off of what the state of Massachusetts had found, because that was where some of the initial cases were. But again, yeah, United Medical trying to take a proactive approach and see what the state is doing, whether it's
Only the
testing.
state can keep up with it, but sometimes, we are limited with what state can and cannot do.
So
So,
it's true. But yeah, so definitely keeping our eyes on that. It is, I think in the CDC, it did go up to the next tier of severity of now from being like cautious to whatever the next step in the cautious ranking is. So it is still developing.
all right. So, um,
In this slide, we also do have, if we're on the same one. Yeah, so this one, we also had topics on brain health with choline. And then also we did want to touch again on the gun violence. As we know, there was another shooting that happened in Tulsa.
I was going to ask Dr. Hosmane this, and then I actually couldn't see the slide. So then
Okay.
I'm trying to follow from here. So there is the concern, because when I was talking to John Donnelly, he doesn't buy these stuff. Like if I say something is really sounds so good, so it's like, well, how about this? But there was a point, but how about cholesterol? So what would be if someone is just trying to get their choline from egg, right? So then they have to eat 3 of them. So then what will happen to the cholesterol is something that I was going to ask Dr. Hosmane, but I forgot.
Yeah.
So we are not telling them do this, but we are just saying that this is a good source of
Yeah. So yeah, we wanted to bring this
brain
up.
food, right?
As we mentioned, June being Alzheimer's Awareness Month, we do know that levels of choline in your system are related to your cognitive abilities and the role in regulating memory, mood, and intelligence. So obviously that does coincide with Alzheimer's and some of the symptoms and impairments that may be experienced by those who do have Alzheimer's. So we wanted to mention that there are things just to even keep your eyes out for, like in the news. If you see an article that says, some foods that may help fight XYZ. So that's why we wanted to mention the choline here. And kind of just its impact.
I just, because of the time, I did jump to our next video, but I don't want to miss the beginning of it. I think we are officially in a World War III.
Yes.
Now, we're not happy about it. We didn't say that we were just saying that this is the direction that we are going in, and everything else is happening around us is also telling this is just escalating and it's not going to get down. I read a lot of European news media, and then compared to here,
Quite different.
they are different. So it's not what we hear, unfortunately, in our news media here. They do sound different than actually what's happening.
Yeah.
What I'm understanding is Russia actually is ahead of the game. And this is actually getting to a point where it's devastating for everyone. But I think one of the best part of maybe the silver lining of this is Turkey actually is still putting a lot of efforts. President Erdogan is even in fact today to help some of the relief from the peers of Ukraine, cleaning the Black Sea from the mines and getting them out. Those talks are happening with the Turkey's leadership. In this one, Sean, I was going to actually, I can give you a heads up. This kind of reminds me of something that I had personally in healthcare that was happening. So when we think that we're helping someone, those parties do have a different plan.
Okay.
And then because if you don't know, like if someone wants to have the war in these places, and then someone is trying to do this
Prevent
peace talk,
Yeah.
they don't care, or they think that that
Yeah.
person is getting in their way.
If they're already on an agenda. It's,
So let me just tell you what happened. So I was in a Medicaid meeting in 2012. One of our lawyers, one of my cardiologists, I believe John Donnelly was there. If he wasn't, then he can correct me. And we were trying to work with the state, their Medicaid population. I won't mention the insurance name because we work with them. So that time, their medical director. So the part that we didn't understand was how the insurance company is not an insurance company, but it's a TPA, the third party administrator. So if it's an insurance company, they care about the cost. But if it's a TPA, they actually don't want the cost down, because if the cost goes down, their fee structure is they charge their fees to the actual cost. So reducing the fee means you're reducing their
revenue,
income, their revenue.
Yeah.
So, and I'm just I probably said this to a lot of people if they work with me closely. I'm not embarrassed. I'm just being openly telling about what I didn't know. In 2012, I didn't understand what TPA was. And because we just know everyone as an insurance company.
Yeah, so you would assume they would have the same.
And then the medical director kind of yelled at me and they said, look, you are trying to reduce my revenue. Why do you think that I would be supporting you? I'm like, look, we are trying to do something good here, so that we are trying to do the value base, and you're going to reduce your costs, and you should be happy. The guy was just attacking me like brutally. And if John is listening, he can, send me a message or something, because I knew that he was there. I have this captured in a written communication, because this is a good lesson for me. It was a good lesson for me where when you don't actually, when others do have different hidden agenda, and when you're trying to do the right thing, you're not going to be welcomed all the time.
Definitely not by
so I see that Turkey's
involved.
position now is almost like that. So they're putting so much effort into the peace and trying to get them on at the same table.
But that may not be what everyone wants.
No. If you look at the weapon importers, exporters, you'll understand why. So maybe Turkey is getting in our way. So don't try too hard.
They're trying to be a helping hand.
So, but why we care? Like today, I took another picture from a gas station.
Yep, I saw.
This time I wasn't Japanese. I was just being regular American Turkish person. It went up again.
Yeah, well, my message back was that I have to switch to the lower octane. I don't know if I can afford
I don't think your car can.
I know.
Yeah.
Don't tell the mechanic.
Yeah.
Tell them still put 93. But
well,
it's getting up
you
there,
may want to think about that. So,
in the long run, it could cost me.
Or you'll get a Tesla.
Yes, I could go electric.
So speaking of Tesla, you send me another file. Let me just see. This was like I was actually talking to Besta earlier, and I'm like, oh, like I get everything done this time, so no problem. And look what I'm. Well, no, I have to get them again. It didn't stay there. It didn't stay. So speaking of you getting Tesla, well, I don't think Biden is going to get one.
He's not a fan.
Is Joe Biden anti-Tesla, therefore is he anti-Elon Musk, right? So he definitely doesn't support him.
No, there's been a history of criticism between the two. Yeah.
And why? Right? So why is it? Because it all comes down to the politics. So someone like Elon Musk, although he's doing so much, the electric cars, if he didn't do what he was doing, today other car companies were not going to support it, or they were not going to follow. So this is not about being American or not. This is about what's right for America. So I wasn't born here, and then I do the right thing for America. So Elon Musk was not born here, and then he's doing the right thing for. But if if you are, criticizing someone, no matter how helpful you are, how much benefit you provide, doesn't matter, because your politics are stopping me to process.
They're going to let that override.
That's just disgusting.
Yeah,
like when they're asking him a question and then he's talking about Ford and others. Like, yes, they're American brand, but this is an American brand.
Right.
So, and I don't own a Tesla, by the way. So he's not ready for me yet. He's gonna make one really nice one. So then I'll get it at that point. But it was kind of sad to see someone like him not being supported just because of the political views. And I think we should be better than that. And that's kind of like interesting. Now, by the way, the Tesla, speaking of Elon Musk, the Twitter deal is off. That window that was given expired today.
Okay.
So that means what Elon Musk was saying about Twitter is true.
Mm-hmm.
So
yeah, they have
more than half of those accounts are not real accounts.
Right. So that goes to make you question again, who's running these, what's their agenda, and the amount of power you can get from these large companies.
So doing the right thing is not that important if you don't have the right political views with those people.
Yeah. Make sure you have the right view, and then you can change the world.
You can change the world after that. So now I know we have one other video, so I'm gonna bring that up.
So we did have a last video kind of on the economy with our debt again. We had a screenshot of the world clock.
So one of the banks I posted on Twitter, they are reducing, like they're actually laying off people 10%.
Mm-hmm. I saw that.
Tesla is reducing their workforce by 10%.
Yeah, he was saying he wants people in the office, or if not, they're just going to downsize.
It's going by like now. These are everything that we've been talking about since October, November timeframe. Unfortunately, people didn't want to see, or maybe there wasn't anything to do. I don't know. Like, we're not saying that people should be listening, and I know a lot of our employees who are watching this, so it's not like we are reaching out to like hundreds of thousands of people, but this is out there, and this could have been prevented. The government making certain mistakes. I see the same thing. Like one of the things that we have, I believe, in these people who are making, couples who are making $250,000 a year.
Yeah, saw that.
They live paycheck to paycheck.
Which is insane to think about. I think that's nuts. I mean, at that type, I would hope you would have some type of financial literacy if you're dealing with that amount of money.
Not in this culture.
Yeah, it appears not.
In today's culture, we spend, and that actually is triggering the inflation, because if you are spending everything that you own, you make every month, you're just spending.
Yeah. So
then you are increasing the demand. So therefore, the inflation is going to go up anyway, and inflation is not 8.3%. So if you believe in that, you are naive. So inflation is minimum 25% in this country, minimum. So I can take the challenge from anyone. If you have less than 25% inflation, to come and talk to me. It's not true. The gas prices, it was the lowest is at $4.75. Lowest one, right? It's $4.75.
Yeah, I mean, you have to go deep south. I think it's like Georgia or Alabama or somewhere down there has the lowest, but it's insane kind of if you think about people who do not make $250,000 but do live paycheck to paycheck, and for them to fill up their car, almost $100 or more than $100.
So impact, but I think the 250,000. The reason I thought it was really interesting is because when you make 250,000 in this country, that's a comfortable number. Not everyone is making that, right? So what they're saying is 1/3 of those people spend entire amount that they make. That means they live beyond their means.
Yeah.
So one of my business associates from the old days, he would tell me, come on, you have to live 20% less than your financial means. So 20%, that means save 20% minimum.
Well, I would say for people, invest that 20%, because if you look at inflation too going up, if you're just sitting on that, I mean, it's obviously better than spending it, but to combat inflation too, definitely invest and hold the investment system.
Absolutely. All right. Well, I know it's time. So we had a really good session with Dr. Hosmane, and he's always good, but today was also even better than our prior ones. So we do thank him, and we have our Bariatric Friday coming up with Dr. Erkan. We are going to discuss intermittent diet. Katrina and Samantha are they are looking for a lot of help and getting a lot of help. So we'll talk about that. And until next time, stay safe and thank you for watching us.
All right. Thank you.